Kelly, and I am a hopeful fluid and electrolyte guru. Today, I would like to speak to you on hypervolemia, hypovolemia, and do a short IV fluid lecture. So let's get started with hypervolemia, okay? Now when I say hypervolemia, I want you to think of too much fluid in the intervascular space first, okay? Now when I say first, I mean what exactly is the vascular space? Well, it can be arteries, veins, heart, any large vessels that contain fluid. So, I want to speak to you about the hypervolemia, and that is, like I said, too much fluid in the intervascular space. Now, the causes of hypervolemia, number one, I want you to think heart failure. Heart failure, anytime you have fluid volume excess, needs to be recognized. Heart failure, what happens is the heart is not working properly. It's weak, which decreases your cardiac output, okay? That decreases your kidney perfusion, which causes urine output not to happen. So that fluid begins to back up into your vascular spaces, okay? Now, renal failure is another cause of fluid volume overload. Same concept. Your kidneys are not being filtered and doing the things that they should be doing. They're not filtering. So therefore, the fluid begins to back up in your intervascular space. Now, also, IV fluids that contain a lot of sodium. Fleet enema contains a lot of sodium. And Alka-Seltzer contains a lot of sodium. Now, what does that mean? Those three things contain a lot of sodium. Now, we have learned before that sodium and water follow each other. For every sodium, there's a water. For every water, there's a sodium. They like to be together because they balance each other out. Now, there are a few times and a few exceptions that this rule does not apply, but for the most part, this rule does apply, and it applies here. If you overload somebody with too many IV fluids that have sodium, water is going to come with the sodium, and you're going to have a fluid volume excess. Okay, now our body really likes to maintain and regulate our fluid volume. Okay, so we have certain mechanisms placed into effect that help regulate this fluid volume. The first I would like to speak to you about is aldosterone. Now, aldosterone is a steroid. It's a mineralocorticoid, matter of fact. Now, aldosterone is found and made in the adrenal cortex, which are, as you know, the penthouse of the kidneys, okay? The penthouse of the kidneys. Now, I'm sorry, the adrenal glands, okay? Which the cortex is in the glands. But, now, the normal action is that when the blood volume gets low, the kidneys sense this. They don't like this. So, what they do is they release aldosterone, which holds sodium, which holds water. Aldosterone causes you to retain sodium and water. Remember that. Aldosterone is sodium and water. Sodium and water. Okay? But if you have a mechanism that causes you to have too much aldosterone, what would that be called? You're right, Cushing's. Now, Cushing's is too much of all the steroids. but aldosterone is in there. And aldosterone is really the one that we kind of need to be worried about here. So Cushing's. Now, when I think of Cushing's, I think of the picture in the Med-Surg book, the round moon face, the small arms and legs, the big old belly, which makes me think of, ooh, they are like a little Cushing, a little Cushing. Okay? That's Cushing's disease. They have too much of all the steroids going on. Okay? And another one is hyperaldosteronism. Go figure. Okay? Hyperaldosteronism, which is also known as Conn's syndrome. Okay? Conn's syndrome. Now, a disease with too little aldosterone is Addington's. Addington's, okay? It would be really nice if we had too little aldosterone to add some to it, right? Addington's disease. Okay, now, I want to go on to our another mechanism, ANP, atrial natriuretic peptide, found in the right atria of the heart. Now, what happens with this is that your atria recognizes so much fluid and it begins to expand like a balloon that's being filled with water. It's bigger and bigger. And so what happens? ANP says, this ain't happening up in here. I don't like to expand. So ANP is released and it causes diuresis of sodium and water. So ANP is actually the opposite of aldosterone. Thank goodness we have an opposite. We have a balancing system here, don't we? Exactly. Now the third thing that I wanted to mention to you about fluid volume regulation is ADH, anti-diuretic hormone. Self-explanatory. No diuretic, anti, okay? So ADH actually causes you to hold on to sodium and water? No. We already have a holder on to sodium and water. It's called aldosterone, okay? ADH just makes you hold on to agua, water, H2O, okay? So that's what ADH does. But let's think about what happens if we have too much ADH or too less ADH. What happens? Too much ADH, syndrome of inappropriate anti-diuretic hormone. Okay? That's way too many letters. SIADH. Come on. Too many letters equals too much water. Okay? Too many letters, too much water. Syndrome of inappropriate anti-diuretic hormone causes you to retain water. Okay? So these people are in fluid volume excess and they're still not going to the bathroom. Okay? Now on the other side of the coin we have diabetes insipidus, also called DI. Now what is DI? DI stands for diuresis. Okay? The problem with this is so much diuresis causes you to go into shock. Now, when you're in shock, what would your normal response to be? The kidneys shut it down, clank, clank, and put a stop on that fluid volume diuresin. But not with diabetes insipidus, they don't. You just keep on putting it out and putting it out. Hey, no, stop. I'm going to die if you keep doing that. They drink and drink and drink, and it flushes and flushes and flushes. Okay? With urinating a whole bunch, your urine is going to be very dilute. Your blood's going to be very concentrated. There's not too much left in there. With holding a lot of water, your blood is going to be very dilute. And your urine is going to be very concentrated. Okay? So, I just want you to think about this. Concentrated makes the numbers go up. Dilution makes the numbers go down. But what are we talking about? 3 things here. Sodium, hematocrit, specific gravity. Those 3 things. When we say these 3 things, we're talking about concentration increase, dilute, decrease, the numbers. For instance, I think about making some apple juice from a concentrated frozen container found at Walmart in the frozen juice section. Okay? I get out my pitcher and I dump that wad of concentrated particles into my pitcher. Now, is this very concentrated or dilute? Concentrated, okay? So if you try to taste it, woo! Too concentrated, okay? So I'm going to add fluid to dilute, 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 dilute. Now what happens to the particles, okay? Concentrated, water, evening out. Ooh, I could take a drink right now. Tastes good. But what if I keep putting more water and more water and more water? I take a drink. Ugh. What happened to my sugar? What happened to my apple flavoring? It's just dilute, okay? So I want you to think about that when you think about the urine, when you think about the blood, okay? Is it going to be concentrated with high numbers or dilute with low particle numbers, okay? Now, ADH, antidiuretic hormone, is found in the pituitary gland, okay? It's right here in the middle of all your stuff, okay? And sometimes some stuff might happen that causes the ADH to be released in a large amount, which would be diabetes insipidus, or not released at all, which would be SIADH, too much water. Okay? Now, what are some of the things that can cause this to happen? I'll tell you. Anything that's got to do with your head and your sinuses and any trauma and increased pressure up here can actually push on that pituitary gland and cause one of those 2 things to happen, okay? So, I just want you to know, if you were a nurse and you're on the floor, okay, and they just had some sinus surgery, or they knocked their head, if these people start pee-peeing a bunch, be aware, okay? Always be thinking, head problems, watch out for that ADH problem. Could be happening, could be happening. We gotta see, okay? Now, things like sinus surgery, transsphenoidal hyposectomy, any condition that leads to an increase. Now, things can't just be simple. ADH has got a separate name. It's called vasopressin. Okay, why can't it just be ADH and let that be? But it's vasopressin. So if you are in diabetes insipidus, you need some ADH. You can sniff vasopressin. It's called DDAVP, desmopressin acetate. Okay? Now, it will help you. Okay? You need it. You need the vasopressin to keep on trucking. Okay? Now let's go back to hypervolemia, which is what we're talking about. Now, the neck veins are what? They're distended and full. I have here, well, first I want to tell you about an example. My hose pipe. I attach the little water faucet on the top because I'm going to spray the yard. I turn on the water, I fill that hose pipe up, and it gets big, right? Right. Okay? Let's remember that with hypervolemia. Now, what happens when my vessel gets... They begin to leak. They leak into the lungs. My lungs are going to sound wet and crackly. Okay. Now, how do we measure that pressure inside? Central venous pressure. The normal central venous pressure is 2 to 6. They insert the line, it runs in, and it sits in the right atria of your heart. And it constantly measures that pressure. Now, do you think that in hypervolemia is going to be up or down? We know it's going to be up. More volume, more pressure. I turn on that hose pipe. Okay? It's the difference between a hose pipe and the fireman's hose pipe. That pressure, whoo, up. Okay? Now, what's going to happen? Your kidneys, nuh-uh, this ain't happening in my body. They're going to try to compensate. They're going to begin to start diuresing to get rid of some of this. How do the kidneys diurese? Well, how do they not diurese? They give you aldosterone. So to not diurese, you withhold the aldosterone. So there ain't no aldosterone happening, I hope, in hypervolemia. Okay? Your pulse is going to be full and bounding, just pulsating, because the heart only wants that fluid to go forward. If it's not going forward, it's coming backwards, okay? And every time the heart stops for just a second, it comes back. We don't want that. I brought a hypervolemic asparagus. This is hypervolemic asparagus. Do you see how full he is? You know, fat asparagus. So my neck vein, whew, it's going to be full and pulsating. My pulse is over here, full, bounding, okay? Hypervolemic asparagus is full of fluid. Now your blood pressure, is it going to be up or down? Raised, more volume, more pressure. Hose pipe, okay? Is your weight going to increase or decrease? You're holding all that water, chick, you're going to be heavier, not a little fatter, matter of fact. Okay? What are we going to do about this? No sodium, that's for sure. Because what happens? Sodium follows water. Water follows sodium. Don't want sodium because I don't want any more water. Okay? Eyes and nose. Anytime you have anybody hypervolemic, hypovolemic, you got to make sure that they're not gaining or losing, or maybe you want them to lose, or maybe you don't want them to lose. So you got to do those I know daily weights. And what? I know that when I'm trying to lose weight and when I'm going to get weighed, I do it first thing in the morning because I know that I weigh less in the morning. I know that I take off my shoes and I weigh in the same outfit every day. I know that I'm going to try to do it at the same time, right? Now, we got to get rid of this fluid. I'm telling you, it's causing some major problems with the heart, lungs. It's starting to get into the interstitial spaces. So we got to have some Lasix, okay? I got to have some Lasix. And if the Lasix doesn't work, I'm taking Bumex, okay? Now, I could also take hydrochlorothiazide, also known as thiazide, okay? But anytime, nurse, remember, if these people are on something that's causing them to diurese, you got to be watching those fluid and electrolyte levels. Lord, we don't want to get their potassium and magnesium and all that stuff out of whack doing. Potassium is excreted, and it's a big deal to worry about. So they also have aldactone, which is a potassium-sparing diuretic. But be careful, because it can put you into hyperkalemia, because it's holding all the potassium. Now, bed rest. Why do we need bed rest? It induces diuresis, okay? Think about it. Right now I'm standing. I got a lot of blood and fluid pooled in the lower part of my body, but if I lay down, all of it comes up to my body. That right atrium and its AMP fills that stretch, so it releases AMP. And the baroreceptors say, I don't think that we need to release some ADH right now. I feel a little full, so they withhold that. Causes you to pee, doesn't it? That's why in the morning, first thing, you got to go pee when you first get up in the mornings, right? Now, physical assessment, you know, you've got an edematous person, you got to be checking them for breakdown of skin, how much fluid do they got, that kind of thing. Check their sacral area, because if they're laying down, they're going to have a lot back there, okay? It also causes the skin to be tight, and it also can cause it to break and tear easier. Now, when you give IV fluids, or you don't give IV fluids, you really need to be careful with the young, the old, and patients that have renal problems. Okay? That can cause a problem. Now, I just want you to remember, when you think of fluid retention, think heart failure first. Okay? I always always want you to assume the worst. Makes you a better nurse. Now, hypovolemia is the opposite, hypo, fluid volume deficit. And I did bring a fluid volume deficit hypovolemic asparagus, okay? This asparagus used to be as big as this asparagus and full and bounding, but now I baked all the water and he is a hypovolemic asparagus now. Not good, not good. Now what can we have? What can cause hypovolemia? We know the obvious. You chop your arm off, you're shooting blood out. Hypovolemia, right there. You've been puking all day, you've been on the pot all day. Nausea, vomiting, diarrhea, lots of fluid coming out right there. We know those things, but actually hypovolemia is when you lose fluid from any way, okay? Thoracentesis, paracentesis, NG2, ascites, okay? It's big and it's in the belly, but it's not in the vascular space, okay? It's gone. It's not in the right spot. Burns cause fluid to seep out into the interstitial space. That's not good. That's not good, okay? Ascites is in the peritoneal. It's not in the vascular. Burns, it's in the interstitial. It's not in the vascular. I'm in a hypovolemic state of mind at this point. Me and hypovolemia, asparagus, are going to date. Okay? The first thing I always really want you to think of is shock. Shock with hypovolemia is very important, okay? Now, let's also think about diseases that can cause us to be hypovolemic. We talked about diabetes insipidus, but there's another kind of diabetes, regular diabetes mellitus, okay? And what happens with that is that the diabetic eats so many glucose particles that the blood is just saturated with glucose particles. It's concentrated, right? Your kidneys, your body, nothing likes that. So your kidneys compensate and try to get rid of that glucose. Now, it has to get rid of the glucose. Do you go sit down on the potty and make a glucose puff? No, you don't. Those glucose particles, particle-induced diuresis, okay? You have to diurese those particles in with your urine to get rid of them, okay? Now, it leads to polyuria, but polyuria is going to lead to olguria, and olguria is going to lead to anuria, and then you've got renal failure. Scary. You don't want it to get that far. So you really need to be careful. Now your weight is decreased. I used to go to the diet doctor. I would try to go as early as I could. I would try not to drink at all because I didn't want what I drank to be counted on the scales. Your weight's going to be down. Look at hypovolemic. Which one do you think weighs more, hypervolemic or hypovolemic? You're going to have decreased skin turgor, dry mucous membrane screaming, I'm very thirsty. And your urine output is going to go down, okay? You don't have enough to output. Either your kidneys are trying to hold on to what they got, no more is getting out down here, or they're not getting enough anyway, okay? There is nothing to be put out, okay? Now, what do you think is going to happen to your blood pressure? Down, less volume, less pressure. You fill up the hose pipe barely, okay? You've only got, like, say your water's only 1/2 of the way full. You turn on the nozzle and it's just going to be nothing much going on there. Your pulse, okay? What's your pulse going to do? Increase or decrease? It's going to increase. It increased with hypervolemia. It increases with hypovolemia. The reason why it increases with hypovolemia is because it's taking what little bit of blood you got and trying to push it out to get everything done, to get everything perfused, okay? The only difference is with hypervolemia, it's full and bounding. With hypovolemia, it's going to be weak and thready, little tiny on your fingers. Now your respirations increased, decreased? Increased. Why? Because your don't have enough going around, so your body senses that as hypoxia, so it increases the respirations to try to get more oxygen, okay? Your extremities are going to be cool. Why? Because vasoconstriction is taking that needed fluid and putting it where it's needed the most. Brain, heart, kidneys, okay? So that warm, luscious, voluptuous blood is not going to your extremities, is it? No. Now the treatment is you've got to prevent any further losses. If you are diabetes insipidus, DVAP, okay? DDAVP, I think. DDAVP, snip it, vasopressin, okay? If you're a diabetic, you need some insulin. We got to have something to carry that glucose, okay? If you had your arm chopped off, you got to put more fluid in, okay? You've got to have a stop to that. Now, with mild deficit, we're just going to drink. With a severe deficit, we're going to give you some IV fluids, okay? But you really need to be careful for your patient. Little old lady, hypovolemic, trying to get up, walk around. She might have a fall, okay? Hypovolemia, you know, low blood pressure, a little dizzy, not getting perfused, not getting all the oxygen I need. You need to be aware falls might happen, okay? You also need to be aware when you're putting that fluid back in, you don't want overload. You don't want to take one thing and go to another extremity, so just be careful. Okay, our quickie IV fluid lecture. Isotonic solutions go into the vascular space and they stay there. If you could measure what was outside of the vascular space in a percentage, 0.9%. Okay? So if I'm putting in 0.9%, it's all even, baby. It's going to stay right there, okay? It's going to stay inside there. This is normal saline, 0.9%. Lactated ringers, D5W, and D5 a quarter normal saline. Now how that works out, I don't know. But D5 and a quarter normal saline equals to be just what it needs to stay. Now, if you've lost fluids through nausea, vomiting, diarrhea, sweating, or trauma, you need to give one of these things. If you are hanging blood, normal saline is the only thing that can be hung with blood, and it has to be hung with blood. Okay? Now, the only bad thing about this is, say you've got a patient that's got hypertension, their blood pressure is really high. Or, let's see, they've got cardiac problems. Do you want even more pressure there? Or they've got renal disease. Do you want your intravascular space to stay where it's at? No. So in this case, you would really want to monitor, not to mention that it can cause fluid volume excess, and that's why we don't want those things to happen with the hypertension, cardiac, and renal. And it can also cause hypernatremia. Why? Sodium follows water. You will be sucking a lot of sodium into the intravascular space, okay? Now, a hypotonic, I think of hypo. And what happens with the hypotonic is that it goes into the intravascular space and then it shifts out into the cells, okay? And replaces cellular fluid. So they rehydrate, but they don't cause hypertension. So when we think of hypertension, we're thinking about the vascular space, okay? So you would want to use these solutions on the cardiac, the renal failure, the hypertensive patients, okay? You're getting the same benefit, however, you're not overloading the vascular space. It's actually going out and hydrating, but in other areas, okay? That's not going to cause as much damage. An example of this was going to be half normal saline, 0.45. If normal saline is an isotonic, then half of that would be hypotonic, okay? 0.33% normal saline, and D2.5W. That's half of D5W, right? Okay. So, if the person has hypernatremia, you want to use this. If their cells are dehydrated, you want to use this. If they have renal failure, cardiac failure, hypertension, you want to use this, okay? But you really need to watch for cellular edema because fluid is moving out into the cells. That could cause a vascular volume deficit, couldn't it? And decrease the blood pressure. Now, the last one I wanted to talk to you about is a hypertonic solution. And hypertonic is just like that big old concentrated apple juice you flopped into the pitcher. It is packed with particles. And when something is packed with particles through osmosis, baby, the water is going to come in, the fluid's going to come in, and it's going to try to even things out. And that's what happens with hypertonic. It's a volume expander, okay? It draws fluid into the vascular space from the cells. Now, there are so many examples. D10W, 3% normal saline, 5% normal saline, D5 lactated ringers, D5.5 normal saline, D5 normal saline, TPN, albumin. Do you know what I think of? Anything that is not normal saline, D5W, lactated ringers, D5 quarter normal saline, half normal saline, 0.33%, and D2.5W. The ones that I just listed are isotonic and hypotonic. Anything that's not in those 5 or 6 is going to be hyper, okay? Hyper. You think of albumin, it's hyper. It pulls, holds it together, right? Now, you can really add anything, any kind of fluid and electrolyte to an isotonic or hypotonic solution to make it hypertonic, okay? I don't even know, just say you put a ton of glucose in there, okay? Now you got a ton in the intravascular space, so it's going to pull stuff from the cells in there. So you can take the isotonic, the hypotonic, add some extra stuff to it, and make it hypertonic, okay? This is important for the client with hyponatremia or somebody that shifted large amounts into the vascular space or third spacing. It kind of pulls it back to where it needs to be. But you really need to watch for fluid volume excess, vascular space excess right here. You're pulling in a bunch of water. This needs to really be done in the ICU where it can be monitored. CVP, baby, okay? Isotonics are crystalloids. Hypertonics are colloids. Thank you.